Awesome, Kish. Well, thank you very much to you and all the other organizers for this invitation. And thanks to everyone for either waking up early, staying late, or finding a little bit of time in the middle of your day to join. I was invited to tell you a little bit about neuroimaging protocols. I hope some of the topics that we discussed today go beyond neuroimaging and probably will help you whether you do fetal body imaging too. I wanted to say that it is difficult to capture everything that we do on a daily basis in protocols. A couple of years back, we put together this effort with my team. It's published in Radiographics, and it has some details. And the reason I'm bringing this up is you'll find a good number of details of the parameters of the sequences that I use at our center in this paper. You'll find some details like TR, TEs, matrix, and voxel size. And the idea is that I hope that between seeing some of the pictures that I'll be presenting here today and perhaps accessing this content, you'll actually be able to reproduce pretty much everything that I have here. There shouldn't be any secret or magic. There's no special trick that we have. And I hope that by making these accessible to you, you can all use it to its full potential. I also want to say that, sure, I do things in a certain way, but there really isn't any secret sauce here. There's more than one way to do fetal imaging, more than one field strength, and more than one coil configuration. And I think that is important to emphasize so that everybody can partake and bring fetal imaging to their practice. You're now seeing a small slide that it's an informal survey of places where I have friends that do fetal imaging. You see that across vendor and across field strength, you can actually get terrific images, and you just have to figure out what works for you. On the left side of the screen, the folks on the West Coast of the United States tend to use 3T imaging on a GE platform, and I think they get terrific images. I may also say that the deep learning options that are available in GE to denoise some of the haste and true phase or balanced steady state free precision images are actually really nice and making a difference for image quality. This image in the middle comes from Cincinnati Children's. They use generally 1.5T and Philips, and I think they do a terrific job. I think those 1.5T images, if nothing, on some of the other 3T images we see from other centers. In particular, at my center in Boston, we do 3T imaging as much as we can, and we use a 30-channel abdominal coil as well as the coil elements embedded in the table of the scan. So I wanted to preface with options that you have available to you, and then I wanted to dive a little deeper on the setup that we have at my center, just to share the one where I think I have the most experience. So at both Boston Children's and MGH, we use a pretty similar setup and vendor. The first thing that we do is we tend to rely on 3T imaging. 3T imaging is great, but the second thing that comes right as next to 3T imaging is maternal comfort. So amongst the 3T systems, I would definitely encourage people to use scanners that have a larger bore. The 70 centimeter bore scanners, I think, perform much better. So if you have a Vita or a Skyra, I tend to favor those over a Prisma. Prismas are great and have great gradient sort of performance, but you won't need that. However, those extra 10 centimeters in radius matter a lot, particularly for a pregnant woman. If you look at the second part of my slide, you'll see the position that we tend to favor. We tend to put moms on their side. They have the abdominal coil sitting on the gravid uterus, and they're lying on the side on the coil elements of the table. We also put pillows in any and every location where we think mom will benefit from having them for comfort. So we definitely support their head, we support their arm, and we put also pillows between their legs. Turns out that every investment you make in maternal comfort will come back as a tremendous investment. The last thing is you have two options. I think either one of those would work. I favor the 30-channel abdominal coil on two fronts. More elements are advantageous in general in terms of SNR, but the second part is you don't always know where the baby is located. So it is totally acceptable to place the coil where you think the baby is located or where you think your highest yield area is. However, you may have to relocate and course correct. In my experience, having a coil array that is larger almost guarantees that you're probably going to capture the fetus. So I like the 30 channel abdominal coil over the 18 channel abdominal coil because just by virtue of its size, you're likely to end up in the appropriate coverage. I do have to admit that for certain populations, 3T presents some challenges. In particular, I think polyhydramnios and conjoined twins with a larger gravid abdomen can present challenges at 3T. So I'm showing you an example of polyhydramnios at 3T with increased artifacts and conjoined twins at 1.5T, which on the other hand came out really well despite a challenging anatomy. Now, getting to our protocols, I think dividing them into basic and advanced is a little tricky. It always is on the beholder to decide how they're going to describe their protocols. For the purposes of the stock, the images on your left constitute what I would consider the bones of the MRI protocol for fetal imaging. The sequences on the right are little bells and whistles that you can add as you need. And I chose to call them advanced, but depending on your practice, you may consider these everyday add-ons or fixtures to your protocol. I still think that the workforce of what we do in fetal imaging consists of really quick structural sequences. The two at the top are the two most common and most important, in my opinion. It's a T2 single shot fast spin echo and a balanced steady state free precession imaging. That's a gradient echo images. I think they balance each other very, very nicely. The T2 spin echo offers nice contrast. The steady state free precession is a gradient echo, so it's very good with bones. I always do a T2 star or EPI image to look for blood products and a T1 gradient echo or T1 vibe or lava just to get a little bit of T1 contrast. I think the T1 contrast is nice to have in the brain, but fundamental in the body to look at the liver, the meconium, and a number of other things. So I will definitely keep it there, but I think it's higher yield in the body. There are other ways to doing T1 imaging in the fetus. There are some single shot inversion recovery sequences. They work nice. However, I favor this just because for me, it's always turned out to be fairly reliable and easy. But there are definitely some spin echo based techniques that work nice. On the more advanced end of things, when we need it, we do diffusion. There's some very nice work on flare imaging, EPI based for fetuses that comes out mostly out of Vienna and other sites in Europe. It's really nice. I try and it comes out and never as pretty as the one in Vienna. So kind of like coffee, Vienna seems to be a good place for that. There are a couple of other ways in which you can use your EPI, and you can even do MR spectroscopy. I have to say, I have never cracked an ad with fetal spectroscopy, but the fact that we can do it is perhaps a conversation worth having. So I'll start at the top of that list with T2 imaging. I think the main advantage of T2 images is that you'll get the closest to purest contrast of the sequences that I described. The T2 images are really nice to depict the zonal anatomy of the developing brain. And I also think that they get a kick out of that 3T images. So if you look a comparison between two 23-week-old fetuses, one at 1.5 and one at 3T, at least to my liking, the one done at 3T has nicer delineation of that zonal anatomy. Those are outlined in the right side of the slide, but I think even looking at it at a distance, you get to see the dark germinal centers, the intermediate zone, the bright subplate, and then the cortical plate really nicely. So I really, really like it when I'm evaluating zonal anatomy, and it is my go-to to look at the brain parenchyma itself. The reason that I prefer it over some of the steady state free precession sequences is I do think that that contrast between the zones of the brain is better on the single shot T2s than on the steady state free precession images. By all means, you can always do better, right? And you can tweak the contrast of your steady state free precession images to try to accentuate the most out of your brain parenchyma. However, there's always more than one chef in this kitchen, at least in my experience, because you're also trying to get from the truth images a lot of information about the body, the bones, the spine. So it's going to be hard to have a T2, sorry, a steady state free precision optimized for every organ. So in my experience, when you land in a comfortable middle, you end up getting better gray white differentiation and zonal anatomy from the T2 and less so from the steady state free precession. Here are a couple of examples of cases where the T2 image is actually really helpful. The first one on the left is a pyruvate dehydrogenase deficiency case, and you can see some cystic necrosis of the ganglionic eminence. So I chose a case where you actually wanted to be able to put the abnormality in a zone of the brain that we discussed. And also, you kind of want the pure-ish T2 contrast so that you know it's not something bright, because the steady-state free precession does have a little bit of intermediate weighting. The second case is a case of tuberous sclerosis. You see a very nice subependymal nodule here. And when you look more closely at the parenchyma, you see tubers. The tubers are dark. And against that background of a brighter fetal white matter, I thought it was easier to see them than in the steady state free precession. And obviously, this works very nice for just morphologic abnormalities like agenesis of the corpus callosum. The steady state free precession sequences, I like them because they're really dependable. The haze sequences can be affected by artifacts of various types. I think the steady state free precession are kind of impervious to that. They're high signal to noise. You can push the resolution. So I actually like them very much. And as I was saying, particularly in very young fetuses, they may still have good zonal anatomy of the brain. I am showing to you that, in my opinion, bearing some foreseen motion, either of mom or fetus. I love them for craniofacial anatomy. I think it comes out great. The gradient echo properties outline the bony interfaces really nicely. So you get to see things like the palate, the nose, the lips very nicely. The palatal shelves, the nasal cavity, those come out great. So I'm a big fan of those. I think you can even get a glimpse at the inner ear with the steady state free precision fairly robustly. So I'm a big fan. Obviously, you'll see the abnormality wherever you catch it in a fetus. It's like buying a lottery, but I do like them quite a bit. Its downside is that it's a mixed T1 and T2 contrast. So should you be in a tough spot trying to characterize the composition of something, I think it's a bit harder. I am giving you a couple of examples where the steady state free precession sequences really helped me. The one on the left is a case of a retinoblastoma, and we pushed the resolution because we thought there was something in the eye, and we were able to see it very nicely. You can also see we did very fine cuts. I know ultrasound does this very well, but we found a really, really subtle cleft lip without cleft palate. That's our second case. Our third case is a case of charge, and you see choanal atresia. You get to see that bony plate in the choana. You get to see that the cochleas are not normal. And you get to see that baby actually has poly, but still the steady state free precession images showed up very nicely for us. I'm also a big proponent of those steady state free precession images to look at the spine. I think the detail is great. The images on the left are from normal spines. The image in the middle is from a hemivertebra and a segmentation anomaly in the lower thoracic spine. The images on the right are from a terminal myelocystocele, and you can see the core that's low-lying and protrusion of some elements and still a skin-covered defect. I'm going to show you some artifacts just because I think you're likely to encounter this. So before moving into some advanced sequences, I want to show you some tricks. Um, as I was saying, the steady state free precession sequences are more sensitive to many artifacts. The dielectric effects, if you have a mom with a large body habitus or polyhydramnios, may come back to haunt you. And the steady state free precession sequences are impervious or relatively impervious to those. I think this comes off at 3T more frequently than at 1.5T. So at 3T, you kind of have to have that steady state free precession image up your sleeve. Flow artifacts are also accentuated in haste as compared to the gradient echo steady state free precession images. So once again, have that available to you. More common if you have polyhydramnios, because that facilitates increased fetal motion. The T1 images, as I mentioned, I think they are a fixture of our protocol. The vibe that we do takes all of 6 to 10 seconds, so it's actually very well tolerated. I prefer to fat suppress them just because I think it increases the dynamic range of the image, but I think you'll get the information that you need. Most of the brain isn't terribly T1 bright. The cortex is a little hyperintense. You get to see the pituitary gland, and that's about it in a normal brain. Keep in mind that the gradient images are flow sensitive. So these are the cervical arteries in an axial plane in a fetus with a dural sinus malformation with arteriovenous shunting. So they increase shunting led to increase in size of those arteries. The third fetus is a fetus with called 4A1, and you see a hematoma. The truth is, you know there was a hematoma because you have HAST images, but still, if you were trying to get at composition, it may help you. The fourth image is a case of goiter, fetal goiter, because of a thyroid organification disorder. The thyroid is T1 hyperintense, so you get a very, very nice look at that. The last of our basic sequences are T2 star images. Oops, great for blood products. So look at the hemorrhage in the cerebellum, germinal matrix hemorrhage, and some congestion on a fetus with a veno-gallin malformation. I wanted to speak English rather than MRI for a couple of these. These are common problems that people encounter. If you have grainy images, your issue is most likely low signal to noise ratio. So a good way to deal with that is to thicken your slices. You'll pay a price in spatial resolution, but you'll recover some of that signal. If your issue is that your images are blurry, you're probably dealing with a problem of spatial resolution. So play with your field of view and your matrix. If you have enough signal, decreasing your field of view and increasing your matrix, I'm sort of showing you a stepwise progress here, will help you deal with those blurry images. So don't assume that because you're using 3T, you're necessarily doing high spatial resolution. You may need to tweak your parameters like your field of view and your matrix to exploit those advantages. A common one is aliasing. Aliasing is simply because the object you're imaging is much larger than your field of view. Frequently occurs in phase encoding direction. The best solution is to do phase oversampling. You can swap phase and frequency encoding, and don't increase your field of view. That's a common pitfall because you'll sacrifice spatial resolution. Banding artifacts are common, particularly in steady-state free precession. The best way I know of dealing with them is turning pre-scan normalize on, and the scanner will calculate the B1 map and inhomogeneities once again. I think that takes care of it frequently, not every time, but it may still help you. Transitioning to the more advanced sequences, EPI FLAIR for fetal imaging, as I was saying, is a very nice add-on. Its claim to fame is that that very watery subplate right underneath the cortex will suppress on flare because it's almost water. So if you don't have the nice expected zonal anatomy, you can suspect that something's gone awry with the arrangement and maturation of the parenchyma. So you have polymicrogyria here, and you see that in that region of polymicrogyria, the subplate is not seen. Fetal diffusion, I like it very much. I don't use it in every protocol. Perhaps I should. It isn't as tricky as it sounds. A couple of things that work for me is drop your B values. You don't need B values of 1,000. B values of 600 save your signal. And if you need a little thicker slices, 4 to 5 millimeters, it's generally okay. You can do DTI and fit a tensor motor. I truly think you probably don't need that. And you just need to remember that the germinal centers and the cortex have lower ADCs. So they appear bright on the diffusion, low on the ADC. These are some examples. I do it whenever I'm dealing with vascular cases. So the exam on the left is a veno-gallin malformation, with ischemic changes from venous congestion. The exam on the right is a dural sinus malformation with clot in the torcula. Difficult to pick up on the background of a dark signal from haste, but restricting diffusion. You can also acquire your EPI images as a cine. This is an example of a fetus with arthrogryposis, and you can see this is by no means normal fetal motion. The fetus is stuck in this position. Numerous ways to apply it. You can think about neural tube defects and motion of the lower extremities and many, many other things. There is really nice work that's been done here in Boston to sort of put a quantitative touch on top of it and analyze the whole fetal body motion, as well as the motion of the extremities, which is modular. The last thing I wanted to show you, and as I was saying, I don't think I've ever directly cracked a nut with fetal spectroscopy, but it can be done. In that fetus with pyruvate dehydrogenase deficiency, I saw a lactate peak. Now, the voxel is so big that's in the ventricle, so I don't necessarily know that that's what was super helpful. At a 35-week-old fetus, just because the fetus is moving less and is much larger, you actually get a fairly decent spectrum. So I don't do it by any means in all of my protocols, but I do think it's something that it's at least worth knowing that it is around and perhaps will come and play a larger role in the future. So with that, I wrap up this early morning talk from here in Boston. I want to say that one of the most important things is to start with the best data possible. So set yourself up for success. Know your coils and invest in patient positioning. Recognize basic artifacts and challenges and how to troubleshoot them. You are likely to encounter them. I love 3T. It has many advantages, but it does present some challenges. So 1.5T is frequently a very robust option that sort of works out of the box without having to scratch your head too much. And in that space, you should plan for technically difficult patients. So patients with a large fatty habitus, those with multiple pregnancies, or those with polyhydramnios are likely to give a headache regardless of your field strength, but particularly at 3T. So with that in mind, thank you very much to all of you for taking time of your day, and I'll pass on the podium to the next speaker. Thank you for the invitation, Kish.